We are also clinical researchers up here, and we are trying to develop new medicines. Please tell me there's something good coming out.
I think there are a lot of exciting agents which are coming out, which are in phase 3 trials right now. There's a PEG-PH20, the phase 3 trial is running right now. There's a STAT3 phase 3 trial is running. There's another pyruvate, more of the I can't say with the metabolic pathway, essentially. I'm just going to make it easy into the metabolic pathway profile. So there are a number of drugs which are coming out in the front line. I think the biggest thing is when I talk about research in the early phase versus patient selection, I think really if we select just third-line patients for some of these trials, it's very hard. So I think earlier patient selection is very important when they're fit enough to get it. And I do think really looking at the tumor microenvironment is a big one, that if you have to break through that shell to get into it. So when I talk to patients, when I talk to researchers, I say it's almost, think about it like chicken soup, right? You have chicken chunky soup in which you have the chicken chunks and you have the soup, and you have to get through the, and people don't, I say it at lunch, at my lunch talks, I show a can of like one of the chicken soups and I say, this is what we're up against. We can take, because there are a lot of preclinical data that's in pancreatic, it's been well documented that we can kill a lot of cell lines very easily, but when we put it into patients, because it is so different more than other, because of all the stroma and everything around it. It's so different that's why these drugs, which look beautiful in preclinical modeling, really don't pan out, unfortunately. So we really need, as exactly as Allyson was saying, better preclinical model organoids, better in which we can replicate the stroma to actually find these agents which can fight these diseases.
Along that line, any role for prophylactic anticoagulation in these patients?
So I think we specifically, in this clinical trial, the PEG-PH20, there were very high rates of blood clots.
But that's to prevent a therapy. I'm just talking about,
So in that trial,
so I think in that trial, it was absolutely critical to give prophylactic anticoagulation, and it made a big difference. The bigger question is people who are not on that trial or until we get a readout. And there certainly are patients who have a high rate of having blood clots. Those super high CA19-9 or those who've been relatively immobile, data has shown that you can reduce the risk of blood clots, but not necessarily change outcomes. And so,
I mean, in that trial, the control arm, the phase 2 study with gemcitabine and PEG-PH20, the rate of, it stopped the trial for a period of time because the rate of thrombosis was close to 50%. But even the control arm with just chemotherapy with gemcitabine, that's our other patients, right, was 25%. And so both groups were treated with, subsequently after the pause, with low molecular weight heparin, and that lowered the rates to less than 10% for both groups. And so I think that there is that question of it is a high rate, but what's the problem is the increased risk of bleeding and other outcomes that you also alter.
And the new oral agent's a little less.
do you use it?
I have not adopted. I have to tell you, I want to. I mean, I see these patients and I think, 1 in 4, maybe 1 in 5 is going to come in with a PE, or we're going, it's that Friday afternoon CT scan.
It's always a Friday afternoon CT scan.
with the PE.
So the Cassini trial, it had the subset of patients with pancreatic cancer. It's there this year in ASCO. So with one of the oral anticoagulants, there was decrease definitely in patients with pancreatic cancer in blood clots, and there was not an increased risk of bleeding. So that's very important also, that we're causing more harm than good. So there was no increased risk of bleeding. There was a statistically significant decreased risk of blood clots, but we don't know if that makes patients live longer. So that part is not there. But we can, we know that if we want to give it, I think you have an argument to give it. That means you don't have increased risk of increased risk of bleeding, less blood clots, but we don't know if it's going to improve the survival in the end.